Hello, everyone, and good evening. We would like to welcome you to the Pheo Para Awareness Week webinar hosted by the American Association of Endocrine Surgeons and in partnership with the Pheo Para Alliance. I'm Paul Graham, an endocrine surgeon and associate professor of surgery at the University of Texas MD Anderson Cancer Center, and I'm one of tonight's moderators.
Hi, my name is Dhaval Patel, and I'm an endocrine surgeon at JFK University Medical Center, a part of the Hackensack Meridian University Health Network, and I'm the other moderator for tonight's webinar. We have assembled an expert panel to answer your questions about pheochromocytomas and paragangliomas. Tonight's webinar is being recorded and will be available on the AAES Facebook page and on the AAES YouTube channel. We would like to thank Pheo Para Alliance for providing us with frequently asked questions from their members. We will also be taking live questions from the audience this evening. You can enter your questions in the comments section directly on the Facebook Live stream. Please be aware that we will not be answering any personal medical questions or providing specific medical advice. For those types of questions or requests, please seek advice from either your doctors or your medical team.
So we will start by introducing and getting to know our panelists in alphabetical order. We will start with Dr. Bancos, an endocrinologist from Mayo Clinic. If you will please tell us a little bit about yourself and your background.
Sure, my name is Irina Bancos. I'm adrenal endocrinologist at Mayo Clinic. It's a pleasure being here in this setting, and I'm looking forward to this. Thank you.
Great. Our next panelist is Dr. Electron Kebebew.
Pleasure to meet you all. I'm an endocrine surgeon at Stanford University. Some people think I'm an endocrinologist. Some people think I'm just a researcher. Some people think I'm a surgeon. I'd like to think I'm all of those things, but my focus is on endocrine oncology and endocrine tumors for my clinical practice. And hopefully we'll be able to share any knowledge I have about the topic.
Excellent, welcome. Dr. Cortney Lee.
I'm an endocrine surgeon at the University of Kentucky in Lexington. I do thyroid, parathyroid, and adrenal surgery, and really interested in the boots on the ground clinical aspects of care of these diseases. So excited to talk about one of our little soapbox topics tonight.
Great. And Dr. Vivian Strong.
I'll take myself off mute. Thank you. Hi, it's a pleasure to be here this evening. I am a surgical oncologist practicing at Memorial Sloan Kettering Cancer Center in New York City. And I'm also a professor of surgery associated with Weill Cornell Medical School. I have a focus in adrenal tumors and gastric cancer. I know it's an interesting mix, but I have an interest in both of these areas, and I'm really delighted to be here this evening to talk about pheochromocytoma and paraganglioma.
Excellent. Thank you to all of our panelists for joining us. We'll now start answering questions. As a reminder, we will not be able to answer any specific medical questions or provide any specific medical advice during this webinar.
All right, I'll start us off with the first question to Dr. Bancos. Could you just give our audience a little bit of an understanding as kind of the distinction between the pheochromocytoma and a paraganglioma?
Yeah, so pheochromocytomas originate from the adrenal glands, and we have two, the left and the right on the top of our kidneys. Paragangliomas are tumors made out of same things as pheochromocytomas, but they are located outside the adrenal gland. Sometimes, I guess my colleague surgeons would agree, it's difficult to make this distinction based on imaging when a paraganglioma is very close to the adrenal gland, but ultimately the treatment is similar, which is surgical. Paraganglioma can occur anywhere from head to pelvis. There are some differences in the proportion of paragangliomas that are functioning versus non-functioning versus pheochromocytomas. The most of those are functioning, but I'll stop here for now.
Well, that was an excellent review over pheochromocytomas and paragangliomas. How do you prepare your surgeon or your patients for surgery?
Yeah, well, I'm the only endocrinologist here, so I'm glad you asked. So, well, we take it quite seriously as far as preparing a person for surgery. I think to start with some basics, we are trying to make a person with a functioning pheochromostomal paraganglioma really insensitive for a potential spillover of catecholamines, which are the hormones produced by these tumors, into the system during the surgery. And if the person is unprepared, what may happen is hypertension, which may be severe and certainly would complicate surgery and surgical outcomes. But now, how do we decide how to do that? That very much depends on individual parameters: how big the tumor is, how functioning it is, the degree of that catecholamine excess. Is it just minimally elevated versus 10 times up a normal range of those metabolites of catecholamines? We also look at whether hypertension already exists in that person with pheochromostomal paraganglioma. Is it controlled? And then we use individual information from those 2 weeks prior to the surgery to learn from patients' experience based on medications and the blood pressure to modify the medications. Now, to put it a bit in a more practical form, each patient with pheochromostomal gets a very good education session on how to measure blood pressure and how to measure the orthostatic vitals. That's the difference in blood pressure between sitting and standing position. And we discuss the side effects of the 2 medications we usually use, the alpha blockers and the beta blockers. The alpha blockers would be phenoxybenzamin and doxazosin. The beta blockers are many, but we usually would prefer some non-selective beta blockers such as propranolol or metoprolol. And what we do, we start with a small dose of first alpha blocker, for example, doxazosin. And once we're satisfied that the optimal treatment with alpha blocker was achieved, that's when we may add another medication called beta blocker. If it sounds complicated, it is. So it needs a lot of back and forth. So I guess my main message is we need to start preparation early. It's not one of those things that a person comes and the next day is surgery.
Great. And Dr. Kebebew, can you talk a little bit as to how important that medical optimization is before surgery and how that affects your surgery and what you see at the time of patients when you manipulate tumor and these specific type of tumors that we're talking about?
Yes, thank you for that, Graham. I think it's extremely important. In fact, this is before we had IRBs and ethical research. There's a famous endocrine surgeon, one of the founding fathers of the American Association of Endocrine Surgeons, who went to Karolinska, I understand, and was performing an adrenalectomy. And they were sampling his catecholamine levels as well as the patient's. And guess what? The surgeon's adrenal glands were squeezing a lot more. So the levels were much higher in the surgeon. On a serious note, though, this is a type of operation that we often say no touch or no manipulation or minimal manipulation is important because the patient could have a spill of catecholamines into their bloodstream and cause, hypertensive crisis, heart failure. So it's extremely important, not only for the sanity of the surgeon, but more importantly, for the patient to not have significant cardiovascular complications during the operation. Another aspect of it is Dr. August does a great job alpha blocking, but you also need a great anesthesiology team that's used to taking care of these patients, because sometimes, regardless how perfectly you block them, they might experience lability in their heart rate or blood pressure. So it's really important to have an anesthesiologist that's used to taking care of these patients and managing a hypertensive crisis as soon as it happens. And then another element is communication between the surgeon and the anesthesiologist team, where you're at a critical point You might have to manipulate the tumor, or for example, you're getting ready to clip the adrenal vein or the main venous drainage, where some patients might experience a drop in their blood pressure. So you want to get your anesthesiologist ready to give the patient pressors should they need to have it. So those are all of the important things. And this is really one disease process where it's really a team effort in the operating room, not only preoperatively, but during the operation. Nowadays, we approach many of these tumors. It used to be that minimally invasive surgery, people wondered that it would be safe, but we know it's very safe and effective in patients with functional paragangliomas or pheochromocytomas. And the outcome and the recovery for these patients is much better than an open approach, unless obviously it's obvious signs of it being a malignant tumor where you'd want to do an open surgical approach for those patients.
Well, that was an excellent overview of what happens in the operating room and the team effort. And actually, one of the members asked a question about outcomes. And so, Dr. Lee, what are the current outcomes for patients undergoing surgery and having pheochromocytomas removed? And this person also asked, does everyone survive surgery at least?
That's a good question. You know, I feel like this is a hard one to answer. Does that, you know, not everyone survives driving the car to work, but I think it's very, very rare to have mortality. And that's our fancy way to talk about people dying after surgery. Very rare after this. When I talk to my residents and students about us performing the surgery for pheochromocytoma, I say my job as a surgeon is technically the same as if I'm taking out a non-functional tumor or whatever. It's really that team approach, having the patient well blocked prior to surgery with the medications that Dr. Bancos was talking about, having an anesthesia team who's experienced in dealing with this and communicating like Dr. Kebebew was talking about as well. The outcomes for this disease are really good. I think it's imperative that we do all of those things to make it safe, not only safe, but straightforward. You know, when you ask, can you do poorly or can you die from the surgery? That's very rare. And I don't know that our goal in this is to live or to die during surgery. I think even if things are you know, not fun for the anesthesia team, and we do have blood pressure fluctuations and whatnot, people will still live. We want to have a nice, boring surgery in the operating room. We want our anesthesia team to be like, well, that wasn't so interesting for us. That's what we want in the operating room. So I think outcomes are really good as far as the surgery, but you do want to make sure that your team is experienced in dealing with this, and that starts at least 2 weeks prior to surgery and getting that appropriate blockade. I also like to tell my patients and residents, once we have you appropriately blocked, there's no urgency for surgery. We can take our time, make sure that we get everybody on board and, you know, have our ducks in a row so that when we do go forth, it's on our terms and everything is as straightforward and safe as possible.
Thank you, Dr. Lee. Dr. Strawn, Dr. Kebebew alluded to a little bit, and patients always ask, you know, why does the tumor have to come out, or is this a cancer, or, you know, what is there to be concerned about in a pheochromocytoma or a paraganglioma, and why are we looking at surgery as a reason for treatment?
Yeah, well, I think that's a great question. And when patients present to me, typically in the office, you know, I think they already have, you know, suspicion of having a pheochromocytoma. At that point, most patients come in with pretty severe hypertension, uncontrolled hypertension, multiple antihypertensives, typically with confirmation, but sometimes we do need to work them up. I think both what the rest of the panelists have mentioned today is very important, that you have a very close relationship with your endocrinologist to make sure that there's good communication and good preoperative blockade, primarily to get the hypertension under control. So I do see patients who come in just on beta blockers, for example, and that's not control, or on a combination of different medications, but not on the alpha selective alpha-1 blockers. So oftentimes it does require quite a discussion with the patients to explain, what we need to do to prepare them preoperatively and how we're going to manage to take this out in a safe way. Many patients say, let's just do this, let's do it tomorrow. But I think the first part is to discuss that if we were not to remove this growth in the pheochromocytoma, these patients will end up with uncontrolled hypertension, which can cause atherosclerotic disease, risk of stroke, risk of heart attack. I've seen several patients who've come in to see me when the diagnosis was made after they had a stroke from a very minor surgical procedure, a cystoscopy in one case. And that's what prompted people to say, why would a healthy 40-year-old have a stroke from a cystoscopy? And they just diagnosed this pheochromocytoma. So I think typically it's not difficult to explain to patients why this needs to be removed. It's going to be a problem that will continue to get worse. Patients do often ask, what is the chance that this could be cancer? There is literature that documents 10% risk of, 10% of pheochromocytomas are cancerous. I'll be interested to see what the rest of the panel thinks. I'm at a dedicated cancer center, and I have to say, I do not think that 10% of the pheochromocytomas that I have removed are malignant. I think the number is quite a bit lower than that. It's not that it doesn't happen, but it would be interesting to talk a little bit about, how we judge the likelihood that a pheochromocytoma, once removed, could recur. There are some interesting scaled scores that we use, like the PASS score, or the pheochromocytoma adrenal scaled score. I believe that's the definition of the acronym, in which we will assign a certain score to the adrenal gland, which gives a likelihood of how aggressive it is and the likelihood that it may recur in the future. So I think I can more or less reassure patients that they don't need to be overly concerned about their pheochromocytoma being malignant, but we need to wait until we get the pathology back and the PASS score. I think all of the other points that the two surgeons on the call made are excellent, Dr. Kebebew and Lee, in terms of having a good discussion with the patient about why they need to be preoperatively prepared. I tell my patients always to be sure to drink about 1 liter of water a day and to really volume load. I also tell them to take salt. I used to tell my patients to take salt tabs, but now I say just have a couple bags of potato chips a day, which they actually really like. That makes patients quite happy. And then also, I don't know if the other surgeons on the call do this, but I tend to admit my patients 1 day before surgery in order to give them extra volume, give them hydration with IV fluids, check their blood levels to make sure that they're really alpha blocked and volume loaded as extensively as possible. And then I think the last point is with the anesthesiologist, absolutely critical. Typically, I'll talk to my anesthesiologist a few days before surgery or a week before surgery. I plan the operation on a day that a small group of dedicated anesthesiologists who are very, good at dealing with these kind of blood pressure fluctuations in the OR to make sure that they're available. And the anesthesiologists typically see the patient the day before surgery or the morning of surgery to really get a good sense of the hemodynamic control that we have. So I think all of these factors are good. I think I've answered your question and perhaps a little bit more, but I think that the points that have been made already are excellent. I just wanted to, support that and to say that I agree with all of that.
Excellent. There's actually a question from Facebook. So if you have a 24-hour urine and plasma catecholamines that are negative, but a tumor is not thought to be secreting, is it possible for it to still be intermittently secreting? For example, during surgery while being manipulated or something like that? Dr. Lee, would you like to answer that question?
Yeah, Dr. Bancos was about to unmute, I know. And
Oh, okay.
No, I'm just kidding. As far as in the operating room, all of the ones, in order to, let me put it this way, I would not think of it, unless it was a paraganglioma, I would not call it a Pheo if it didn't meet biochemical definition of a Pheo. In other words, if it met criteria to take out, I would find that out on final pathology. Do you know what I mean? If it was non-functioning. And so therefore, I would not block that patient. And, you know, I have not taken one out thus far that I found that out on final pathology. Typically, if they are non-functioning, we will not treat preoperatively and would not expect to have significant intraoperative problems. I also do get 24-hour urine is good too, but I like plasma fractionated metanephrines as well for that. I feel like it's just a tad bit more sensitive too, and so that's what I tend to get on incidentalomas when I'm considering a possible diagnosis of Pheo.
May I add one thing to that? At our institution, we have seen a few patients with von Hippel-Lindau syndrome, and actually those patients can sometimes have sporadic secretion of catecholamines, which are not necessarily picked up on plasma metanephrines and catecholamines. So if a patient has and they can be very significant, secretions, but they happen sporadically. So for those patients, I will get 24-hour urine studies instead of plasma studies, but that could be the one exception. Maybe that's what this person was asking. I'm not sure, but just to add that point.
And I also have another point to add to what was discussed already. In a person with a genetic syndrome, such as VHL or von Hippel-Lindau syndrome, or let's say recurrent contralateral pheochromocytoma and MEN, when the pretest probability, meaning even before we order 24-hour urine catecholamines, for pheochromocytoma is high. We have an indeterminate looking adrenal mass in a person likely to have pheochromocytoma. I think it's important to know that the amount of catecholamines that particular pheochromocytoma is capable to produce is dependent on the size. So it is quite possible that it is a secreting pheochromocytoma that is just not big enough to get the catecholamine amount above the cutoff level, which we would consider abnormal. And those would be situations we would pre-treat, with alpha blockers, just because of that high likelihood that we are dealing with a functioning pheochromocytoma, but just maybe a smaller one, because I think it's still likely to spill out the catecholamines.
Dr. Bancos, can I ask you a question? And what about the very large pheochromocytomas that have centralized necrosis? Can those also be situations like that?
Yes. So in fact, at our institution, whenever we think we're dealing with pheochromocytoma or paraganglioma in the abdomen, we would pre-treat. There's a second question from Facebook. What about paragangliomas in the carotid region? Those we wouldn't, because those are non-functioning and people do quite well without any pretreatment. But almost every other situation in the abdomen we would pre-treat. There's also cystic pheochromocytomas. That's another, sometimes dilemma. I guess we would. Would you do something different? Anyone on the call would?
If I had high suspicion, I would definitely treat. I would give them as much as they could tolerate to become a little orthostatic hypotension, a little nasal stuffiness. If you're using phenoxybenzamine, I would definitely treat. I always like to err on the side of a little post-op hypotension than any sort of intra-op hypertension. So,
yeah, I was just going to add, my view is it's likely for it to be functioning. It can be episodic. But even if the biochemical testing is negative, both for head and neck paragangliomas, we always block those patients. In my view, you get one chance to get it right. It is a potentially functioning tumor. And the downside to alpha blockade in a monitored setting is pretty minimal. So in my practices, everybody gets blocked. Generally, if the tumor is greater than 2 centimeters. I could understand if it's a head and neck paraganglioma less than 2 centimeters, that you might not block them, but to me, it just makes great sense to avoid any hypertensive crisis and consequent complications.
And that level may be different for each individual, correct?
That level, I'm sorry?
Of blockade, of medical
Yes,
optimization.
it's normotensive. It's not like you're going to need them on mega doses of the alpha blockade. So very true. And then just to add, build up upon, it's all in the genes for this disease process. My gosh, in the last 2 decades, we've learned is, the rule of 10% should be the rule of 10 plus genes. Rate of malignancy. I've taken care of plenty of patients with a malignant metastatic pheochromocytoma, and it's really based on making sure the patients get genetic testing. The size of the tumor gives you an idea. So, I think one of the questions was, should we resect all non-functioning paragangliomas? We've done studies demonstrating patients with SDH-D and C, those paragangliomas rarely become malignant or metastatic. Unfortunately, we don't have a good diagnostic test. Even the pathologic analysis is inaccurate for distinguishing between benign and malignant tumors, as opposed to patients with an SDH-B mutation that have head and neck paragangliomas. We'll resect those when they're just a centimeter in size because of their high risk of being malignant. So just to back up and answer that question, really, most of these tumors should be resected. And one of the reasons I think even the one on biochemical testing that we think is not functioning is anecdotally, many patients note that they're developed depression. I've taken care of many kids that were diagnosed with ADHD that ended up having a pheochromocytoma or a paraganglioma. And I think to me that proves that some or many of these tumors could be episodically functioning. So I block everybody. Most of the paragangliomas should be resected depending upon the genetic background.
And just to add, in terms of the genetic testing at my institution, every patient that I see with a paraganglioma or pheochromocytoma is getting genetic testing because we found that over 50% of these patients will end up having some SDH mutation. I mean, Dr. Bancos may be able to talk more about this, but we are doing testing for all of our patients that have either tumor.
Same, even older people with pheochromocytomas. I know previously we've been kind of debating, should it be just paragangliomas or just younger people? I actually don't make a distinction. Anyone with this rare disorder gets an advice to see a geneticist and be tested.
Same.
And this is, I agree, I do the same thing, and I didn't 10 years ago when I came into practice, but it is recommended now. I just did a review of this to give a talk last year, and about every 5 years, we have had another, 5 or 10, about 5% of these are due, 10%, 15, 20, 20, or like Dr. Strong said, we're up to 40, 50% of these now are due to germline mutations. And the deal is, it just lets you know we have more that we haven't found yet. I have a patient right now booked with bilateral pheochromocytomas, and I was all excited to see which mutation he had, and he does not have one. And, I think everyone on this call would agree that he likely does have one that we may not know yet or whatnot, or maybe the one that looks like a Pheo on MIBG isn't. But point is there's a lot we have to learn, and that is changing so rapidly. It makes for an interesting treatment algorithm for us.
Can I ask the panelists, would you operate on a patient without the genetic testing result back that has a pheochromocytoma or a paraganglioma? And this might be relevant to the audience as well.
Well, I'm not operating, but I would definitely send them for surgery and then get the genetic testing 3 weeks later. I guess, in my practice, it needs to get out anyway. So what genetic testing is helpful to me and to my patients is to advise on future management. How frequent do we monitor? What is a chance for another tumor to come along? What is a chance of metastatic disease? And obviously testing of the family. So, but it doesn't really have much implications to the surgical choice for that particular tumor. Unless I see a neck paraganglioma, and then I would want an abdominal imaging before removing the neck paraganglioma because of the likelihood of multiple tumor to exist. But then again, I don't need genetic testing telling me that. I just need abdominal imaging.
Yeah, I would not typically do genetic testing before removing a paraganglioma. I'm curious, Dr. Kebebew, why you asked that question. What is your practice?
My practice is to wait for it because we've discovered some patients with VHL, and that might have just a 2-centimeter tumor. And I would do a cortical sparing adrenalectomy in the patient because they have a lifetime of getting Pheos in the future. So preserve as much cortical function. Similarly, if it's a 7-centimeter pheochromocytoma or paraganglioma and the patient is SDHB, germline mutant positive, I would approach that patient with an open approach and actually do lymphadenectomy. Actually, Dr. Patel and Ellis generated a lot of this data that shows that it totally impacts the type of at least surgical intervention that we undertook. So that's why I was asking the question. But it sounds like it's not routine practice amongst the endocrine surgeons or even the endocrinologists.
I would say it's very common to have other syndromic features in von Hippel-Lindau and MEN, or even neurofibromatosis type 1. So we're talking about the ones that are not as visible in physical exam and history. I guess I'm not completely sold on that. So I would not want a person to be with pheochromocytoma for 3 extra weeks waiting for genetic testing.
I started smiling when I heard you ask this question because on our adrenalectomy guidelines task force, we've had this discussion and there are a bunch of different thought processes on that. I don't always get it, but if I were in a situation that you're describing where I have a suspicion of malignancy based on size or whatnot, knowing it's SDHB would, I think that would help. This patient looks like he has bilateral, Pheos, the ones I just mentioned. And so having it back or not, doesn't necessarily change my surgical plan. However, I will tell you this, the fact that it is negative, I'm going to have our nuclear medicine doctors go back and look at that MIBG a little bit better, make sure we don't have a false positive, but we'll still probably address both of those. So I think that it can play a role. And I think it's important to, it's important, for the patients on this call, it's just important to go to someone that understands the pros and cons of that and can think through that and come up with a good decision one way or the other. I know there's a lot of different ways to approach it and think about it. You just want to make sure you're seeing somebody that knows those nuances and can approach it and think about it and come up with the right plan.
And I'd like to add that I think, for example, if I were to see a patient with a 7-centimeter Pheo or one that had any kind of malignant potential, I think that, we can talk about whether minimally invasive or not. That's sort of another topic to discuss if the group wants to get into that. But I think every time that an adrenal tumor is removed, at least I remove it as if it's a malignancy. I always treat every one of the tumors, make sure that you don't injure the cortex. You make sure that you remove the entire area with all the surrounding lymphatic tissue. And I think that's always important. So, having very good technique, whether that's minimally invasive or open, that's up to the skill of the surgeon and the judgment of the surgeon. But I think that's the most important factor. And I don't think that genetic testing would alter my approach. It would always be to remove the whole tumor with the surrounding areas, especially if there were any question of malignancy or invasion into surrounding organs. So, yeah.
I would like also to add some of the decision-making is cortical sparing adrenalectomy for those patients likely to have bilateral disease. Especially the questions comes along, what if a person likely to have bilateral pheochromocytoma in the future currently presents only with one? And would it be helpful to actually have genetic analysis for that single pheochromocytoma to decide on cortical sparing adrenalectomy for that unilateral disorder? So I think what's also important to note here is the risk of recurrence. If you leave, let's just imagine bilateral pheochromocytomas, I think there is a risk of recurrent disease versus primary adrenal insufficiency forever, right? And I know it's when I have this discussion with my patients, would you like cortical sparing adrenalectomy for your bilateral disease versus, but a small chance that it would recur in the future because you will still have some tissue left behind versus adrenal insufficiency forever. I have to admit, a lot of patients choose adrenal insufficiency forever. So, and they do well. So I know that there are a lot of people are quite scared about primary adrenal insufficiency after bilateral adrenalectomy, but that has not been my experience with my patients or our experience at our institution for patients choosing to have bilateral adrenalectomy to treat bilateral pheochromocytomas. Yeah.
Dr. Lee, to kind of follow that a little bit, can you tell us a little bit more about kind of the difference between some of the nomenclature, and a specific listener asked about the WHO classification of malignant changing from malignant pheochromocytomas to metastatic pheochromocytomas. So in our discussions, we've talked a little bit about, tumors recurring either in left over adrenal tissue or where it was before, versus those that may show up in areas where adrenal tissue or pheochromocytoma type tissue shouldn't be present, and how that kind of plays into what you would technically call this, and why that and that's important in our follow-up of our patients.
Pheochromocytoma is always tricky when we're talking about cancer. When is it cancer? When is it not? And I agree with Dr. Strong. I think it probably is quite a bit less than 10%, but patients ask that. And I make a big point at that preoperative visit to say, listen, we're not really going to be able to tell you after surgery whether this is cancer or not. And so that's why they've kind of gotten away from malignant pheochromocytoma to talk about metastatic pheochromocytoma. In other words, they're like, well, doctor, how do we know when it, how will I know if it's cancer? And I say, well, if it comes back. Now, since we just got finished talking about cortical sparing adrenalectomies and genetic syndromes, it's very important we differentiate the two topics we're talking about. So if somebody has a genetic syndrome that predisposes them to getting pheochromocytomas, they are going to be more likely to develop more than one. So they can have more than one in a gland. I did a lady several months ago that had 5. She had 3 in one and 2 in the other. So that's what we see in genetic disease. And so if somebody has genetic disease, except for the SDHB, most of them aren't cancer, but you can have an additional pheo come back, i.e. not necessarily the one you took out, but a new one. That's not cancer, and that's not what Dr. Graham's talking about or asking me about right now. So that's a different story. When we talk about taking out a gland, and then we have pheo that shows up elsewhere where it's not supposed to be, i.e. it's not in the adrenal and it's not a new paraganglioma, i.e. we have pheo in the bone, metastatic anywhere else in the body, that is not where we would expect to see a pheochromocytoma or a paraganglioma, and that we would call metastatic disease. And if somebody shows up with disease outside of where it should be, that's when we would call that metastatic pheochromocytoma, or i.e. cancer. Because we can't call a pheo cancer on that final pathology for the most part, that is why we follow patients yearly for a long time, and make sure that those levels stay down and that we don't have evidence of recurrence. So it is tricky on the nomenclature, and I feel like I'm a country surgeon half the time, and I'm like, this is all kind of can just make it confusing when it doesn't necessarily need to be. But I think it's important to know that our pathologists can't cut it and tell us if it's cancer or not. And we need to know that it can come back. Now, there's definitely things that make us more concerned. You've heard us mention many times these tumors greater than 5 centimeters. Those are going to be a little bit more concerning than those less than 5 centimeters, et cetera. So there's definitely things that raise our suspicion or make us more concerned, but the reality is we tend to follow all of these patients and look for recurrence of disease. And that can be recurrence of disease from cancer, i.e. metastatic pheochromocytoma, or recurrence of, oh yeah, your genetic testing was negative, or nobody ever tested you for genetic testing, and now it's come up again and you have a second pheo because you had a genetic mutation that we didn't know about. So those are the two different reasons we follow people with metanephrines longer term.
Dr. Bancos, some people use the GAP score or PASS score to try to figure out if someone is metastatic. Do you use it at your institution? And if you have a high PASS score, one member on Facebook asked, does that indicate you have metastatic disease or the potential for metastatic disease?
Well, none of the current scoring systems are very accurate. So what that means, I'm not able to tell my patient there is 0% risk based on your past score, or whatever other scoring system you use, that you may develop metastatic pheochromocytoma in the future, or vice versa. If it's a more worrisome past score, there's actually not 100% chance that this person will develop recurrence of metastatic cancer. So as Dr. Lee mentioned, our approach at our institution, our approach is to monitor every person the same way, as if they all have the same potential, low potential to develop cancer, and that's lifelong. And that would include 24-hour urine for catecholamines and metanephrines once a year forever. And that, though for all those people without positive genetic association, and that would be various type of combination of scans and frequency of scans with yearly 24-hour urine catecholamines for those with genetic association.
Thank you. Dr. Kebebew, you probably see some patients though that come in and they come in with a Pheo or paraganglioma and then have metastatic disease at the time of presentation. How do you evaluate those? How do you go about working that patient and treating that patient? Is it any different?
Yes, well, the first order of business is to determine the extent of disease. And if the patient has had only anatomic imaging, this is probably one situation. I actually do it in also patients with just a solitary pheochromocytoma to do functional imaging. That could be FDG PET or dotatate to help you detect other sites of metastatic disease or other primaries. And then once you've assessed the extent of disease, the determination of whether all of the tumor sites could be completely resected. So patients might have liver metastasis, lung metastasis, bone metastasis, and might require engagement of a multidisciplinary surgical team, talking to your colleagues in thoracic surgery for lung metastasis. But if it's resectable and one could achieve an R0 resection, we call it, that's negative microscopic and gross margins, then those patients should be offered surgical treatment. And at least based on our studies, these patients actually have a very good, durable, disease-free interval of anywhere from 2.5 to 3 years. Understanding and discussing with the patient that likelihood of developing metastatic recurrent disease is high. In some instances, if it's a functional tumor and we could only achieve what's called an R1 resection, where it's microscopic positive margins, those also patients benefit with respect to hypertension and symptoms associated with a functional tumor. And then I think the area we really don't know for sure is when we cannot completely resect it, should we be resecting the primary tumor or the liver metastasis? And there's not any great data, but I've generally offered patients a debulking operation, not debulking the tumor where you're leaving gross positive margins, but knowing that the patient has bone metastasis. Anecdotally, those lesions tend to be non-functional, so they might still benefit if they have a functional tumor. So that's been our general approach in these patients as far as the surgical management.
At our institution, I'd like to add that we do also, for a patient that would have widespread bone disease and metastatic disease, we would consider radioactive labeled MIBG treatments as well. And that has been very helpful in slowing down disease. You can't cure, at that stage, but in slowing down this disease, which sometimes can be relatively indolent in certain cases. I've seen, young people with metastatic Pheo who've been on radio-labeled MIBG treatment and have had very durable long-term suppression or, quiescing of the disease. So that's another option to be considered.
Dr. Bancos, what other options other than surgery for metastatic pheochromocytoma are there? What medical treatments and options? I know Dr. Strong just alluded to MIBG treatment, but what else is out there?
Okay, I'll have to pace myself so I don't talk too much about that. So what I would like to talk about three things here. So first, I really would like to make a point that most patients with metastatic disease do very well. So, and actually do not progress on any treatment, without any treatment. And it's majority of the patients, at least out of, if the audience is interested in looking at our published data on 271 patients with metastatic pheochromocytomas, only a quarter actually had aggressive metastatic disease. I think it's important to what we like saying at our institution to make sure that the therapy matches the aggressiveness of disease. The second thing, talking about the therapies that are available, I think because most paragangliomas present with bone disease, lung disease, or liver disease, as far as metastatic, we could always attempt a non-systemic therapy. So at our institution, we use ablation quite a bit, which is localized treatment of metastasis with great success, and also external beam radiation for this metastasis. So I would say most of my patients, if they need treatment, they would be treated with these localized treatments. The third thing I would like to say, and then I'll give the stage to someone else to talk about other therapies, is that some patients with metastatic unresectable disease do have functioning disease. So it's important to make sure that they're properly treated for this catecholamine excess, either with daily doxazosin or very rarely with some other medications such as metiricin. So I'll stop for now.
Thank you. Dr. Strawn, one of our listeners had asked earlier if there were any steps that could be done prior to surgery to reduce the tumor size, et cetera. So we're talking about steps that maybe are done after surgery or in lieu of surgery for people with advanced disease. In other cancers, we do some therapies before surgery. Is there anything similar or in Pheos and paragangliomas?
That would probably be a question that I'd direct to Dr. Bancos here. We typically, I don't typically know of a treatment beforehand to decrease the size of a Pheo. Dr. Bancos, enlighten us a little more, please.
So thankfully, my experience is limited in that. And why I say thankfully is because most patients do not need to do that. So we've actually tried shrinking the tumor only in several situations that I remember of. And all of these situations, patients presented with very large tumors where our excellent adrenal surgeons deemed that even if we shrink it by a little bit, it would be a much easier surgery. And I have to admit that success of using chemotherapy for this purpose for 3 months, that's what we've done, was pretty bad. So I think that we've learned on the several situations that probably it's not worthwhile going through all of this toxic therapy and attempt to shrink the tumor, which is not quite shrinkable, except by surgery. I don't know if anyone else has better experience, but that's my limited experience. We would go for surgery with a very good surgeon.
That is true. It's a very rare event, but I have operated on patients that responded remarkably well to CVD, where the tumor initially was not resectable, where they had an appreciable response, and we resected them. I think no more than 5 or 6 patients in my career.
Dr. Kebebew, can you just explain to the viewers what CVD is? I don't think everyone may not know, the listeners.
Phosphamide, vincristine, and doxorubicin. That's my medical oncology head. Especially the patients with SDHP, for some reason, might respond better to that. There's some literature on
that. Thank you. And I guess, Dr. Lee, can you talk a little bit about any other therapies and why, I guess, in terms of, people have asked about whole body scans and MIBG, but what's specific to Pheo and paragangliomas that open up different types of treatment beyond kind of our routine systemic treatments like chemotherapy?
sorry, this is getting out of my wheelhouse, but I will, so thanks. But I'll kind of tell you what I think. First of all, I see when would we do a whole body scan? When would we do these other things? And Dr. Bancos mentioned some of this earlier. When we have patients that have genetic or germline mutations that predispose them to Pheo Para ganglioma, that's when we would include imaging and surveillance. If we don't have that higher risk, then usually we would just do the biochemical evaluation and surveillance. When we start talking about a whole body scan, we can think about functional imaging, and i.e. nuclear imaging. Traditionally, it's been MIBG. They inject you with a nuclear tracer and do a study. And that's the one that I'd mentioned earlier. That radio tracer gets preferentially taken up by these by pheochromocytomas, so it can kind of help us differentiate between a tumor that may be a pheo versus one that isn't. That study can also help look for distant sites of disease, i.e. does just the adrenal light up, or do other places in the body light up? And that can affect treatment and help us know preoperatively before we do the surgery whether or not we are suspicious of the patient already having metastatic disease. It may change the way we treat the patient. The other thing, the other reason that MIBG may be helpful preoperatively, if we are a little bit suspicious, is to see if the tumor takes up MIBG. Was mentioned earlier, we can actually use that as a therapeutic option to treat distant disease. And I've had a patient where we've done that. So that it can be a therapeutic thing as well as a diagnostic study. I will say for most Pheo patients that come, I don't get any functional imaging preoperatively, but I think there's definitely roles for it for both diagnostic and if you are suspicious of metastatic disease for therapeutics.
That was excellent. Question from one of the members is, Dr. Strong, where are paragangliomas located? And, do you do this with another surgeon? Let's say there's a bladder paraganglioma or a paraganglioma in the chest. Do you do this as a combined procedure? And are there typically different symptoms for where it's located?
So I think that's probably the question best directed to Dr. Bancos. And I think Dr. Kebebew also is talking about doing some paragangliomas in the neck. I mean, we're very specialized at our center. So if we were having paragangliomas in the head and neck area, we would do that in conjunction with our head and neck surgeons. Or if it were in the bladder, we would do it in conjunction with our urologist. So, but Dr. Kebebew may have a different answer for us, and Dr. Lee as well. So let them answer.
Yeah, so I think it really depends upon the surgeon you're seeing. I'm an endocrine surgeon, so I operate on endocrine tumors in all parts of the body except the brain. And even if it's in the chest, my thoracic surgeons always ask me to come help him. And you are right, the location in some instances, the symptoms might be different. Some patients that have, for example, bladder paragangliomas might have hypertensive crisis. We actually recently discussed a patient here on peeing. So the symptoms could be definitely variable depending upon the location of the tumor, even if it's functional. And yes, so for bladder paragangliomas, we would do that with our urology colleagues as well as a combined case. So it really depends what institution you're going to and what the expertise of your surgeon is. I think the most important thing is going to a center focused on this so you can get the best medical, surgical, radiologic, medical oncology team if there should be a necessary need for it, rather. And I think with that, you'll get the appropriate care.
Absolutely. Thank you for that. Dr. Bancos, when we talk about, we've talked a lot about the genetic signature and this specific type of tumor and what it means in terms of treatment of our patient. A lot of our patients will ask, when we have such strong discussions about genetic background is, how this affects family members, or should their family members be tested, or, is there a risk of passing this on to their family? And can you talk just briefly about how genetic testing in family members plays out in Pheos and paragangliomas?
Yeah, so just to start with the fact that I recommend genetic testing to any patient with pheochromocytoma and paraganglioma, regardless of age and regardless of family history of similar type of tumors. So, and what I tell my patients that I would use this information in two different ways. One, for individualization of management for my patient, how frequently to follow, what kind of imaging to consider, and at what frequency that imaging should be done. But then the second reason for genetic testing is if it is positive, for my patient to have an opportunity to share this information with all his blood-related family members, so that family members can consider testing. So we can even provide a letter explaining to make it easier for our patients to share this with their family members, to explain what exactly this means and why this is important. And there's nothing we can do about, convincing those family members to consider testing. Some do, some don't. And those who do sometimes get positive results or be reassured that they don't have the same genetic association. Now, most of these disorders are autosomal dominant. What it means is that you inherited, unless you're the first person in your family having this genetic predisposition, you inherited from one of your parents. And what it means that you have 50% chance to pass this particular genetic association to your child. And what does it mean, 50%? Well, sometimes you can have 4 kids and none are affected, but sometimes you have 4 kids and all are affected. So it's not necessarily perfect math. So I hope I answered this question. So I guess if their family members do test positive, then they should meet with either geneticist or an endocrinologist to come up with a monitoring plan. For example, in my clinic, I have a lot of carriers. So they never had disease, never had pheochromocytoma paraganglioma, but they have the genetic predisposition to that. So we have to decide based on the gene and the penetrance and what it is, what type of imaging we do and how frequent for that carrier of disease.
Dr. Bancos, I have a question. It's one on here as well, and I think it's interesting. I have my bias after looking at everything, but they ask, would you recommend genetic testing if a patient has had genetic testing 10 years ago and it didn't show anything? Should they be retested? When should you consider retesting, et cetera?
Yeah, it's an easy answer for me because every time I see a person with negative genetic testing, but where I suspect that it's unlikely to be negative, for example, a 23-year-old with abdominal paraganglioma, I always advise my patients to reconsider testing in 5 to 10 years. My spiel is that genetic advances are made every day. So it's things change and it may actually have clinical implications. So definitely. Another thing I add that 5 years from now, I may be adding something else to my advice and to my counseling, to my management, because this field is moving forward rather quickly, I would say. So I guess I would be if there's a debate around it, I would be in the group of people proposing retesting.
And not to be the contentious one, and the completely everything that Dr. Bancos says, I just wanted to emphasize for the patients and their family in regards to genetic testing, there's actually been studies to demonstrate if you do test positive, that your outcome is better as a result of the screening and surveillance. The disease is caught much, much earlier. So I think that's an important point. Whenever it's an inherited disease, I think some family members might be a little anxious about it, very normal. But the impact and their management and their outcome, I think, is pretty remarkable. So just to add to what Dr. Bancos said.
Well, we won't call that contentious at all, Dr. Kebebew. And it's a good way to end. As we approach the top of the hour, we'd like to thank our viewers and supporters for joining us this evening. A special thanks to all our expert panelists for taking the time out of their busy schedules and to answer our questions and our viewers' questions and to discuss the Pheo Para Awareness Week. And we want to thank the Pheo Para Alliance as well for their support in this event.
And as a reminder, this session it was recorded and it'll be available on the AES Facebook page and on the AES YouTube channel. For more helpful information for patients, please be sure to visit the AAES patient education website. That's at www.collectedmed.com/AAES patient education. AES staff will also post this web address in the Facebook live stream as well. Thank you. Have a good night.
Thank you. Good night, everyone.
Thank you, everyone.
Thanks.
All right, great job, everyone.
Well, thank you. Thanks so much for